everybody. My name's Andrew Tutt from the Institute of Cancer Research and King's College London. Welcome to our debate, a slightly different format to much of San Antonio. We're going to keep this light and airy. I am assured that my two debaters are going to behave well. I believe how we do things here, if they don't behave well, is turn the mics off. So I'll be ready to do that. Our topic is a motion of all patients, and that is patients, so patients with breast cancer, not the population as a whole. All patients should be offered germline testing. So these are my disclosures. So what I'd like you to do is scan the QR code, which you'll see come up in a moment, to use the Slido app so that before our two genetics gladiators do battle for your pleasure, you can tell us your thoughts on this motion before they've had a chance to influence you. And then we'll see again at the end of their display what you feel. So I'm really grateful to our two genetics gladiators, Dr. Allison Kurian from Stanford University, California, and Dr. Raymond Kim from Princess Margaret Hospital Cancer Center for taking the positions that they are going to take in this debate. So if you could scan the Slido and begin to declare your pre-debate position here. Just going to give this a little time because you can also do this online if you're watching the debate online, and that may take just slightly longer. So we're just going to give this a few minutes. Gosh, no pressure, Raymond. No pressure on you here. Okay, we're stable, and things are stabilizing. Oh, the no voters are late to the party, it would seem. Okay. All right, so roughly 2/3 feel that all patients should be offered germline testing. And again, to point out, this is patients, this isn't population. And 1/3 no at the beginning of this debate. So now, what we're going to do is allow Allison to influence you. And then at the end of that, if there's time, take a couple of burning questions from the floor. I don't think we'll be able to do this from online. And then we'll clear the gladiatorial ring and allow Raymond the stage to convince you in the other direction. Okay, so Allison, thank you.
Well, thank you. I am thrilled to be here at this exciting contest. And I have to say thank you all for the initial vote. I suppose I have nowhere to go but down, so I'm going to do my best here. But very excited to be here. So all patients should be offered germline testing pro. Let's see if I can advance my slides. There we go. Maybe? Very good. All right. All right, so here are the arguments for testing all patients. I'm going to summarize them first, and then we'll go through in detail. Argument 1, and most importantly, is clinical utility. Argument 2 is the prevalence of pathogenic variants. Argument 3, guidelines. Argument 4 is cost effectiveness. 5 is gaps and disparities in testing as it is currently happening. And 6 is positive downstream effects. So here we go. Targeted therapy, I think, is the best reason to make sure we don't miss a breast cancer patient with a BRCA1, BRCA2, or other important gene mutation. This is the study many of us know very well from Olympia, led by our colleague Dr. Tutt and others, and initially in 2021 presented and showing a wonderful disease-free survival advantage, this is the second publication that showed a clear overall survival advantage in 2022 for patients getting adjuvant olaparib versus placebo. And of course, we heard yet another very good-looking update at this meeting earlier this week. And of course, this followed on trials in the metastatic setting. Talazoparib and olaparib have been shown to improve progression-free survival for women with metastatic disease, and BRCA1, BRCA2, and increasingly PALB2 pathogenic variants as well. Targeted screening is another important benefit of finding out that people have BRCA mutations. Now, I'm going to be showing you some data from the primary setting, so people who didn't have breast cancer yet, but I'm going to ask you to consider the fact that this very likely will have benefit in patients who did not have a double mastectomy and thus have remaining breast tissue as well. So the first on the left is a figure from an ASCO presentation this past year, which I was fortunate to discuss by our colleague Dr. Lambertini, that showed that women who had breast cancer and got their genetic test before diagnosis had better survival than women who were tested only at the time of diagnosis. This study did not track what kind of screening people got, but it's very likely that this is a screening effect. On the right, we have a study from earlier this year by Lubinsky and colleagues where they did look at MRI-based breast screening before diagnosis in patients with BRCA1 or BRCA2 pathogenic variants and did show an association of lower mortality. Keep in mind, these are not randomized, but association studies. And so I think do continue to make the case that screening here and potentially secondary screening could also be a reason to test everybody. So what about the prevalence of pathogenic variants? Are these very rare, things we're unlikely to miss if we don't test everybody? The answer to that is no. This was a very influential paper by Dr. Yadav and colleagues at the Mayo Clinic, published back in 2020, where they had a sample of all comers with breast cancer, women not selected for any particular reason. More than 3,900 patients. And what you can see here in the figure is the likelihood of finding a pathogenic variant in various combinations of breast cancer genes. Blue is BRCA1 or BRCA2. Red is 6 high-risk genes, BRCA1 and 2, CDH1, PALB2, PTEN, and TP53. And green is all of those plus 3 moderate penetrance genes, ATM, CHEK2, and NF1. And what you can see here is they looked at it by the number of affected first and second degree relatives. So let me call your attention to the bank of results here on the left and show that even if there is no family history, if we think we're interested in knowing about the 9 breast cancer genes, which I think we are nearly at a 5% prevalence overall. And it only goes up from there with family history. So what about other data for older women? This is a study that we did with colleagues about 5 years ago where we were interested in the prevalence of pathogenic variants for women who got diagnosed at older ages, which at least historically was thought to be a reason not to test people because the pathogenic variant prevalence was low. Well, here we randomly selected 2195 women who had enrolled in the Women's Health Initiative when they were postmenopausal and cancer-free. And we looked at women who developed breast cancer over time by doing genetic testing. So I'm going to call your attention here to the blue, which is BRCA1, and the red, which is other breast cancer genes, and show you that for women diagnosed between ages 50 and 59 and 60 and 64, the prevalence of having a BRCA1 or 2 gene mutation was about 2.2%. Now, that's a very similar number to the carrier frequency of BRCA mutations in people of Ashkenazi Jewish ancestry, which is often considered a reasonable criterion for offering testing. And now looking at both the blue and the red together, with red being the other breast cancer genes that we just showed on the last slide, again, the probability of having about a 4 to 5% chance of having one of these is really maintained from age 50 up through age 79. So even in older women, not so rare, and I think make a good argument for testing everyone. What about guidelines? Well, guidelines do their best to consolidate information across existing publications with experts. And here in the US, we have three main sets of guidelines that speak to this. One being that of the American Society of Clinical Oncology, which this year came out and said that everybody diagnosed at age 65 or younger should be tested based on the two prior slides I just showed you of those studies. And as you see, they have a laundry list of other good reasons to test people who were diagnosed at age older than 65. National Comprehensive Cancer Network says 50 or younger, but we see an even longer list of reasons you might want to test someone who didn't fall in that group. And 5 years ago, the American Society of Breast Surgeons just came out and said genetic testing should be made available to all patients with a history of breast cancer. So I think we're seeing them converge on a similar position. See if I can move forward. Yes, I can. Now, what about cost? Often people think, genetic testing is so expensive. Can we really afford to do this? And I started in this field more than 2 decades ago when it really was very expensive, but now costs have come way down thanks to next generation sequencing and other methodology, and it is covered by most insurances in the United States. So this was an important paper by Dr. Manchanda and colleagues in the UK in 2018 who looked at different strategies for testing people. And so they looked at the standard criteria of family history-based testing for just BRCA1 and 2, that was the solid line. They looked at family history-based testing for a larger group of genes here, and that was the dashed line. And then they looked at population-based testing, actually of everybody, for this set of genes. And what we see here is interesting. That when we look at a willingness to pay threshold of $50,000 per quality-adjusted life year saved, we actually see that broader population testing is getting more and more cost-effective because you are saving lives by finding people early. And just to put it in context, this threshold was actually established by dialysis. So in the United States, what we're willing to pay for dialysis for patients, just to put it in context. So what about gaps? How well are we doing with what we're doing right now? We do have some data on that. An important paper from last year by Dr. Lau Min and colleagues at Penn used Flatiron Health to collect data from electronic medical records, primarily of community practices, and found that from 2011 to 2020, testing did rise for breast cancer, remain low for ovarian cancer, but still, not perhaps exactly where one might like it to be. Our team looked at a broad population of everybody diagnosed with cancer in Georgia and California, so catchment area of 50 million people, and looked across cancer types at who had genetic testing results. And I direct your attention here to the orange line, which is female breast cancer. We're still seeing fewer than 30%. This was 2019 diagnoses with genetic data through 2021. And you can see that we're not where we should be when you look at the whole population. And another big problem is disparities in terms of where things currently stand. This is also from the Cancer Registry. Here, we were looking at racial differences in testing. In this case, all cancer types except breast and ovarian, more than 1.1 million people. And we can see disparities by race. The dark gray is white, non-Hispanic. Below that, Asian. Blue is Hispanic, orange, African American, or Black. But it's even worse when we look at breast and ovarian cancer, which is hard to believe because we know we should test these people. And what that's about is non-Hispanic white women getting tested, although not at the rates we'd like to see, but other people not getting tested as well. So I think we need to be careful about anything that might put barriers in the way of testing, particularly any confusing rules that say test fewer than all breast cancer patients. What are the causes of the potential gaps that we see? This is a survey we conducted nearly 10 years ago now and published about 7 years ago in JAMA, asking women from cancer registries who had clear indications for testing. They were diagnosed young, they had triple-negative breast cancer, they had strong family history. Why didn't you get genetic testing? And here, the most common reason was this: my doctor didn't recommend it. Not it was too expensive, not I didn't want it, showing us that we as clinicians have power here. And I think we have to be careful not to be thinking so much about excluding certain groups from testing, and that a simplified policy of testing all breast cancer patients might help with closing these gaps. Now, I also want to talk about downstream effects of broader testing. One concern that has been appropriately raised has been about variants of uncertain significance, which we do see more often when we test for more genes and when we test in populations that haven't been tested so much. The main worry has been that they might be mismanaged by being treated like a pathogenic variant, meaning that people would be getting bilateral mastectomy that wasn't indicated or bilateral salpingo-oophorectomy. This is certainly not a resolved question, but there are data, and a study in which I was involved and presented at ASCO last June looked at claims data from the Komodo data set, as well as genetic testing data from Invitae Laboratory, and was able to say that for some of the things we worry about, like bilateral mastectomy and risk-reducing bilateral salpingo-oophorectomy, when you compare women with a VUS in purple, women testing negative in blue and positive in green, you do see a clear separation that the people with variants of uncertain significance are getting care more like those testing negative than those testing positive. We see that here with BSO as well. Again, not conclusive, but I think reassuring that we're not seeing widespread mismanagement here. And finally, a really important positive downstream effect, and that is cascade testing. As you all know, our current policy is not to test every person at birth. So how do we find people before they're diagnosed with cancer that have a pathogenic variant? The standard in this country is cascade testing. So you test a patient with cancer, you then test their relatives and go from there. And that's how you find people before cancer happens, to be able to give them precision prevention and risk assessment. And so what we see here from a recent study by Heald et al. Is that in doing this, about half of the relatives who got tested were negative. 44% of them had the familial pathogenic variant in the family, but another 6% even had something else. So my point being that when you go testing in a cascade situation, you find a lot of carriers, and that is important. A really brilliant paper by Dr. Offit and colleagues at Memorial Sloan Kettering looked at this 5 years ago as a thought experiment. And what they wanted to know was, how long will it take us to find all the pathogenic variant carriers in the United States so that we can appropriately screen them and offer prevention? And we look here at time in years. So how long will it take us to find them all? And here on the x-axis, we have what proportion of patients with cancer are being tested. And then these different curves talk about how many relatives are getting tested. So if we don't test very many cancer patients, maybe only 15%, and we only test their first-degree relatives, it's going to take us a long time, upwards of 30 years, to find everybody. Whereas if we do a good job testing 70% of first, second, and third-degree relatives, and we do a good job of testing a large proportion of cancer patients, we could find everybody in less than 10 years. So just giving you a sense of the power of testing adequately in terms of cancer patients and going on to test their relatives. So I want to conclude, finishing argument here, by saying, in terms of clinical utility, targeted treatment and screening reduce mortality. Prevalence, pathogenic variants are not rare in any subset, really, of breast cancer patients. Guidelines, they are converging from multiple expert organizations towards testing everyone with breast cancer. Cost, the cost effectiveness at standard willingness to pay thresholds is actually better with wider than narrower testing. Gaps and disparities, there's persistent undertesting, worse in minoritized groups. And finally, downstream effects, that cascade testing identifies unaffected carriers, and we're seeing some early reassuring data that there doesn't seem to be a lot of mismanagement with VUS. So I will stop here and thank you.
Thank you, Allison. Thank you very much indeed, Dr. Kurian. If you mind just waiting at the microphone for a moment, I think we do have time to pose a couple of questions to you, if there are any questions from the floor, to understand what Allison's just presented and see how that influences if that might influence your voting going forward. While you're thinking, if any of you are, I just want to point out that I've been very clear that neither of these speakers should see each other's arguments or slides beforehand. I went to the speaker ready room and made sure that there was no chance of imposters pretending to be the other speaker and seeing slides. So Raymond will not have seen Allison's argument until just now, and neither could Allison prepare by having seen Raymond's argument. So we're keeping this very, very Queensberry rules, shall we say, in this debate. But it does not look as if there is anyone. Oh, no, there is. Over at the microphone on my right.
I'm Ashwini Bhatt, Baylor Scott and White here in Central Texas. I had a question, and I don't know if it's a question for the audience too, in the recent years when we have offered genetic testing, some of my patients have declined it, stating that if they do get diagnosed with the pathogenic gene, whatever it is, not just the BRCA1, life insurance denies them all benefits. So they are refraining from getting the genetic testing in spite of the health benefits.
So if I may answer that, I will say that yes, I think that is still a gap. As we know, in this country, we do have protections for other aspects, for health insurance, and for other things through two things. One, the GINA Act of 2008, and subsequently Obamacare. But there is a gap in terms of life insurance. And so I have not seen actual data published on rates of denial. I don't know if I'm missing those. I know it's a worry people have. And when people have that worry, we typically encourage them, if they are thinking about testing, that if they wish to pursue life insurance before they have tested, that would be a reasonable time to do it if they are concerned.
Thank you.
And if I could take a question just to my right, in the middle.
So this is Homera Sarfraz. I'm one of the breast medical oncologists at UAB Birmingham. Two questions and comments, I guess, like piggybacking on one of the questions from earlier. So when we talk about genetic testing in general and applying principles not to the US, but globally, we're talking about countries where we're struggling really with just about, we're picking between what we should invest, because no matter how cheap it gets at the end of the day, it's access, it's investment. So how do we go about approaching that? And my second question, and this is something as fortunate to train at programs where we had access not just to genetic testing, but genetic counselors. So that is one area where I feel like I really hope that we will have more folks looking into it, because this is a growing field. There's a lot of data, a lot of opportunity, where really without them, I think we're somewhat lost. Thank you.
Dr. Tutt, I don't want to take more than my time, so I will respond quickly that I agree it is a challenge, and I think for each country this would be something they would need to prioritize in light of what they have in terms of options for treatment and options for managing cancer. Personally, I think genetic counselors are national treasures. Maybe I should say international treasures. We need more of them. I do think that's improving, though not fast enough. And so resources, both for testing and for appropriate downstream management, are key and need to evolve along with testing approaches.
I'm going to take one quick question, quick answer, please, on my left.
Jacek Jasem, Gdańsk, Poland. I don't want to question your arguments because I believe your opponent doesn't need any help. However, I have one question, because you said recommendations, guidelines, but they counter your arguments, because two of three American societies advise using tests only in selected population. The only society is breast surgeons, but they may have some conflict of interest, because many patients will opt for mastectomy.
So I believe I said that they were converging toward, so I don't think you can say it contradicts my argument. And in fact, what we see is that they are moving toward testing people in broader age ranges. I don't think we're 100% there with all of them, but I think we're inching toward it, and it reflects where the evidence is going. Thank you.
Thank you very much, and thank you for that gladiatorial question. It's raising the temperature in a way I like. Okay, so we now ask, thank you very much, Dr. Kurian. You may rest. And now, Dr. Kim, over to you.
So thanks for the committee for inviting me. More importantly, thanks to my last question there, my friend, and the 35% that are helping me. Unlike my esteemed counterpart who relies on very rigorous data, I'm not going to present a lot of complicated graphs that as a geneticist I don't understand. But I will try to argue against universal germline genetic testing. My name is Raymond Kim. I'm from the Princess Margaret Cancer Center. So I'd like to start by celebrating that 30 years since it's been about 30 years since the BRCA1 gene was discovered. And here's a brief timeline of the seminal events chronicled by Alan Ashworth from pathobiology, patients, and PARP inhibitors, the 3 Ps. And being at an international conference, I'd like to point out that Canadians Stephen Nayrod and Patricia Tonin contributed to this effort. Here I am with Stephen, and he's signing his new book, A Fair Trial, The Foundations of Breast Cancer. Please let me know if you purchase this, and I will get Stephen to sign your copy. And this is my only financial disclosure for this talk. And to keep it international, for the Koreans in the crowd, here's Stephen and I playing Korean drinking games, made famous by American pop star Bruno Mars and K-pop star Rosé. So now that I've proven my credibility to the audience, or the lack thereof, let's talk about the science of universal testing for breast cancer patients. Now, here are the genetic testing criteria that the NCCN uses for highly penetrant genes. They are quite complex with many permutations and a combination of cancer and family history. Furthermore, there are dozens of laboratories who offer genetic testing, and it likely depends on your insurance, on which companies your insurance will cover. And finally, as you can see with the DNA stack of paper, the amount of paperwork that genetic testing is voluminous, because us geneticists wanted to make it difficult for everybody else. Now, despite this, here is the history of genetic testing in Ontario. Before 2000, it was mainly done on a research basis or sent to our frenemies in Salt Lake City. Then we had testing for BRCA1 and 2 and some Lynch syndrome genes that was a usual standard of care for over a decade. And in 2013, the Supreme Court overturned gene patents, and US companies started offering next-generation sequencing panels. In 2016, this starts to occur in Ontario and coincides with the approval of PARP inhibitors for ovarian cancer, and BRCA1 and 2 tumor testing becomes standard of care. And in 2021, Ontario updated the genetic testing guidelines, which were panel-based, and here they are. They encompass a dozen different categories, including breast cancer, and encompass 76 genes offered in 9 hospital-based laboratories. For breast cancer, here are our criteria, similar to NCCN with a little bit of permutation, where breast under 45, ovarian cancer, other categories receive genetic testing based on family history, and the 19 genes are listed here on the breast panel. Now, we analyzed this for the first year, where over 10,000 tests were completed, 7,000 on breast cancer panels, and had a gene positivity rate of about 10%, suggesting that these criteria work and there's no need for universal testing. And yes, there is a movement of universal testing in the literature, including some large studies here, which I'll dissect a little bit. This all stemmed from the paper from the American Society of Breast Surgeons that boldly state genetic testing should be made available for all patients with a personal history of breast cancer. However, there's very little direction to the community on how to go about this, and the arguments against universal testing include: what genes are we going to test? What results should be used in the management of breast cancer patients? Some considerations include, is it BRCA1 and 2 alone? A panel should include ovarian cancer genes. What about the results? How are they incorporated in patient care? Are there any safety considerations when widespread testing is used, such as variants of uncertain significance, which we heard about in yesterday's session on the future of cancer genetics and even today. Here's a large paper from Bob Nussbaum where you see high yield when you test for a large panel, the 80 big gene panel. However, the positivity rate drops significantly for BRCA and when you test for the relevant genes, suggesting that yes, if the panel is large enough, you're going to find out find many mutations, but many of these mutations may not be relevant for a breast cancer patient. Similarly, coming out of the Mayo study, a large panel is used, but many of these genes are not relevant in the breast cancer context, and more relevant for endometrial cancer and carrier status for recessive conditions. So the rationale for finding mutations when testing is universally implemented starts to break down because, yes, you'll find mutations, but that's because the panel is so large. So this uncertainty on the relevance of these newer genes in breast cancer patients is reflected in the evolution of the NCCN guidelines. Back in 2014, there was very little guidance of the use of these panels and how to incorporate them into practice. Some genes are listed in a simple table where MRI, risk-reducing surgery could be considered for breast and ovaries. And these guidelines have changed drastically over time. And how can we keep up with this in a universal testing scenario? To address which genes cause disease, the clinical genetics community has been tackling this through various initiatives such as the Clinical Genome Resource and Genomics in England panel app. Here, when you search for a gene and see if it causes disease, and it pops up. And here you see BRCA1 and 2 cause breast cancer very clearly. But newer genes such as BRIP1, available on almost all panels, do not cause breast cancer and is in fact refuted. So the applicability of this gene in a breast cancer patient needs to be questioned. In fact, when you search up hereditary breast carcinoma, you see many of these genes on panels are listed as refuted or disputed. In particular, Lynch syndrome does not cause hereditary breast cancer, but is almost on every breast cancer gene panel. And these discrepancies are reflected in NCCN, where the management is separated from breast cancer and ovarian cancer, which is great. But this audience knows here that breast cancer is not ovarian cancer, so the panel needs to be selected very carefully, and this starts to break down when you move to a universal approach. However, despite their best efforts, I would also like to highlight that NCCN is only expert opinion, and we should proceed with caution before making decisions based on lower grade 2A evidence, suggesting even these well-accepted guidelines, should they be adopted, knowing the evidence is weaker, can change and has a profound impact when you launch things in a universal setting. In terms of genetic testing results, they are generally categorized in 5 different levels. Pathogenic, likely pathogenic are clinically actionable. Variants of uncertain significance, likely benign, benign do not and are not clinically actionable. However, even this is not straightforward in a context of a large, big cancer gene panel. For example, if you find a pathogenic mutation in some genes and you are testing a patient with breast cancer, why you tested them makes a huge difference in the clinical management, such as LZTR1, which causes hereditary schwannomatosis, SDHA causes hereditary paraganglioma. Here, if you find a patient who has a likely pathogenic or pathogenic variant in these 2 genes, and you conducted it because the patient had breast cancer, and there is no history of schwannomatosis or hereditary paraganglioma, and despite having a gene-positive results, the societies say that you actually shouldn't monitor these patients as someone who has hereditary schwannomatosis or hereditary paraganglioma, because the genetic testing alone and the gene positivity of likely pathogenic and pathogenic is not enough to change medical management. So you can imagine, bigger does not mean better. Universal may cause more confusion, and an identified pathogenic variant may not be clinically actionable. Now, what about these uncertain results, or these VUS, which are called the big bad wolf? Here, despite the preliminary data that Dr. Kurian has presented, this has stood the test of peer review. And many patients who have these uncertain results undergo bilateral mastectomy, which suggests that variants of uncertain significance are still a clinical conundrum. And I think we should listen to this paper, and many of you may know the first author of this paper, suggesting that too many variants of uncertain significance may cause confusion. Variants of uncertain significance are a conundrum, and they actually are not all created equal. Variants at the end of the spectrum have a 90% likelihood of causing disease, or not causing disease. But that means everything in between is lumped together. A variant that has 85% in causing disease is listed as a variant of uncertain significance, or these hot VUS. And a variant that is only 15% likely to cause disease is also classified as a variant of uncertain significance, or a cold VUS. Now, these create discrepancies in the labs, and variants can change over time. And with widespread genetic testing, such as universal, this is only going to get worse. Part of this nuanced communication should be done by genetic counselors, but there is a dearth of genetics professionals to meet this demand, as seen this report to congressional committees. Another reason that universal genetic testing should be taken with a lot of caution. So what is the best compromise? It seems ASCO suggests that breast under 65 is the sweet spot, which strikes a balance of utility and yield. And if you can read the writing very carefully, it says this was done with rigorous review using a systematic approach. Again, I think we should listen to the authors of the paper, which some of you may know. Therefore, I suggest you join the geneticists and join the Dream Gene team. We know genes and vote against universal genetic testing. The reasons are we don't know what genes to test for, and there are genes with limited evidence and utility. Breast cancer is not ovarian cancer. Variants of uncertain significance are a clinical hazard. Genetic awareness and the workforce is limited. So again, to my 35% people, thank you for your support. I'm looking for another 25%. Thank you.
Dr. Kim, please stay at the microphone. So, Romans in the galleries of the Colosseum, you have an opportunity to question Dr. Kim before I then ask you to think about revoting. So if you would like to come to the mic and ask a question, please do. I'll give you a minute or two to do that. Not seeing, oh no, yes. So we have a question on my far left.
Hi, my name is Dr. Hilary Dietz. I'm a community oncologist in Ithaca, New York. We have no access to genetic counseling within our health system or our community. So I do all the counseling, I review all the results with our patients. And I think that reflects a lot of community practices within this country, at least. I would be interested for y'all's opinions on, the genetic counselor has a role to select patients who are appropriate for testing, but also to help interpret testing. And so in the setting of like a dearth of genetic counselors, do you think that it's better to have universal testing so we're not missing patients, or better to be more appropriately selective so that we're not getting more results we don't know what to do with?
So I agree with all your points, and you're actually quite a unicorn who is able to do so much in your busy clinic, include genetic testing and interpret and deliver that care. Now, genetic counselors are moving away from the selection of actual people to test, and in fact, in our clinic, we seldom do that process, and most of the testing is done by the oncologist. It's interpreting those results, and then also thinking about the family, which is very important, and facilitating that cascade testing, which I think we can all agree is really the importance and the opportunity in preventing cancer. So I think depending on your situation, there is a role for genetic counselors in the era of genetic testing, and then even more in the era of universal genetic testing. But for the time being, there's not enough of them, so just please vote for me.
And one question just in front of me on my right.
Okay. I have conflict of interest. I've received a nice Toronto Blue Jays T-shirt from Raymond. So.
You weren't supposed to say that.
Consider it declared.
I tried to stack the deck, but it wasn't working. I even submitted my slides on time.
Yeah, I controlled the speaker ready room, but I didn't control the audience.
I
So,
can get you California T-shirts. California T-shirts.
So,
okay, it's getting
points.
nasty. Go ahead.
First of all, yeah, totally agree with the high penetrance genes. The problem that we face in moderate penetrance genes and low penetrance genes is really exhausting in clinic. What are the next steps? Cascade testing, etc. However, I'm going to talk about our experience in Middle East. The median age of our population is really low. So almost by age, around 90% of our breast cancer patient in Jordan fits the ASCO guidelines. So because of that, and because we don't have genetic counselors, etc., it seems we are going to go to universal testing. But this is our experience because of the difference in age demographic in Jordan than in developed countries.
Thank you. I think it's also context specific, and it's nice to see that the age threshold of 65 seems quite reasonable and what people actually can remember. So perhaps we should take that guidance from ASCO, but that excludes people who are over 65 and have no family history and are not triple negative, which the utility may not be so great. So again, arguments against. Thank you.
Great. Raymond, if you'd come and have a seat, thank you. So if I can have the voting slides up, please. So again, you're going to see this is our motion. Sorry, you've seen the motion, but the motion's at the bottom there, actually. All patients, not the whole population, all patients with breast cancer should be offered germline genetic testing. Yes for Allison Kurian's argument, no for Raymond Kim's argument, and you're going to see in a moment the Slido app QR code, so just get that into your phone. So we can go to the voting slide. How actually I do that? That's me.
While people vote,
No, you've had
I'd
your time.
like to take a page from the American political experience, where those
Can we
who
turn the
wear
mics
red
off,
hats
please? Mics off.
seem to win. So I brought my own special festive red hat from Canada upon the recommendation of my children. So hopefully this will sway against.
Cut the mics, please, team. Cut the mics.
So hopefully my red hat will get some more votes.
Can you take us back a slide to the voting slide, please? Or maybe I'll do that. Here we go. So let's try and get us back on it. Here we are. Okay, have we got a stable? Oh wow, there has been some change. I think we'll.
The red hat did it. What
Yeah,
are you gonna do?
it's.
My kids will be very happy. Thank you.
We
are
call
in
that a cheap
Texas,
trick
right?
in the UK.
Yeah.
But I do just want to point out that I want to thank both our speakers, and I'm going to show you some evidence that I think at least one of you may have had some internal struggles in accepting your role against the motion and the position that we gave you. And so, it would seem many of you are going to be ordering these tests on your breast cancer patients. I know that we've heard that...
It's do as I say, not as I do.
Be careful with the result. Reach out and value genetic counselors. Argue for more of them to be available, and be very careful with the genes on those panels that may not be so relevant to the decision that you're seeking to make for your patient. And VUSs, as we heard in a beautiful session at San Antonio, are constantly being reevaluated, and reach out for help in interpreting them if need be. I'd like to thank both our speakers very much for rising to the challenge. I hope you found it a scientifically important but also mildly entertaining session.